improve that interaction with the patient in the future. So the Right Care initiative, again, we're still trying to decide how we will evolve with including heart failure as part of our efforts here, but it certainly does impose a clinical and economic burden on the system. There are multiple treatments that I think we could enhance the care for patients, and it makes some sense to me to include it. Many of the efforts that we're working on for preventing stroke and stroke and MI, again, the underlying pathologies are somewhat similar, and so we've got a platform that we're starting with, and I think we just have to figure out how to innovatively incorporate our efforts at heart failure as well. So thank you, like hearts. And what I'd like to do is now give you the more interesting talk with Dr. Sanjeev Bhavnani from Scripps, and I think you'll find it very enjoyable.
Somebody else was going to be formally introducing Dr. Sanjeev Bhavnani. He is an assistant professor of medicine in cardiology at the Scripps Clinic and Research Foundation and the principal investigator of healthcare innovation and practice transformation. He is a visiting professor of innovation in medicine from Toronto. And instead of reading his whole bio, you all have that there. I just want to say that we had a lovely visit with him and his team in San Diego last month, and we very much appreciate the opportunity to collaborate with you, Sanjeev. Thank you for making the trip up.
Thank you so much. Lovely introduction. Patty, Carol, Cheryl, everyone here, thank you very much for extending the kind invitation. Quite the platform. Hopefully this will be exciting enough. If not, there's coffee outside. But hopefully for us to think in a little bit of a different direction. So at Scripps, I'm a clinical cardiologist. Heart failure, heart transplants, focus, cardiac intensive care, and left ventricular assist devices. But on the academic side, I'm involved in designing clinical trials around new technologies. Fortunately, just like Los Angeles, live in a hub of innovation where we have access to new technologies, new data, new ways of thinking, but really trying to create an evidence base for how such new technologies can be applied in research and then hopefully for patient care. My disclosures. I've asked this question before in different audiences of who has a smartphone, knowing everybody here has a smartphone. I will ask the follow-up question. Do you use a mHealth device as part of your healthcare? Just by show of hands. A, yes, all the time. So 3, 4, 5, 6. Yes, but only when my spouse tells me to. Probably not. No, I'm figuring it out. And then finally, what's mHealth? So we have a room of about 30 plus people. 5 are using a mobile health device, and we live in an innovation center of Los Angeles. Interesting. So have any of you prescribed an mHealth device to a patient? You have. May I ask, what have you prescribed?
It's actually been my dad, since I don't see patients myself. Thank you. It's actually my dad, since I don't see patients myself, he's diabetic and is on dialysis. And he uses a CGM and connects that to his smartphone, although according to CMS, he's not supposed to.
But he took control of his health in his own hands. He's monitoring his own data. How interesting. Okay.
And his daughter can monitor it from afar.
Well, I haven't gotten that far, but that's true.
You could do it, yeah.
Yeah.
So I think we're seeing, and just an introduction, that there's a gap between what we're going to see and know versus what we do and then need to do. So using the RightCare initiative framework for how evidence is generated, but specifically around patient-centered practice redesign. Now that ultimately is whom we're designing for and why we need to design new principles. So we'll use this as a framework as we bring together what we'll do over the next 1 hour, and that is how do we move from technology to data to knowledge. I'll skip over a lot of what the introduction was on the current burden of heart failure, the therapies, the conventional therapies, and really for us to think in new directions centered around digital health, mobile health, and data-driven healthcare. We'll go through high-tech care, that's digital health or M-health, mobile health, which will include web-supported care, new innovations, and ready for today's delivery on remote patient monitoring. The value in how we need to also design with human-centric innovation. This is not just about technology, this is about people. We'll move then to big data and precision health, new ways of individualizing care, and in this example for high-risk heart failure patients, what type of insights we can glean from that, and then new directions. That includes new systems of care. So digital transformation has many definitions. The one that several of us have come up with that seems to fit is the tools, processes, and procedures allowing organizations to create, manipulate, and manage patients in an individualized approach using new data sets. But yet again, it's not just about devices and technology. It moves from device to data to knowledge and aims to answer clinically meaningful questions that lead to improved efficiencies and outcomes. In this digital transformation, it is a dynamic and changing paradigm. We have to address the rising burden of disease and cost containment, but we have new vectors to be able to achieve those. That's through digital and virtual health. The consumerism of healthcare now, and as described from your father, and perhaps other dads and moms of ours that are procuring their own healthcare online.
Can we stop and just ask how many of you are caring for an elder or a family member or who've had a heart attack, stroke, or heart failure or diabetes?
Oh, another great example of a gap, right, between what we need to do and where we are. Absolutely. And that patient-centric design. The new ways also of looking at this are open data and data transparency. I think I heard earlier, perhaps before we spoke, on well, what type of data do patients need to have access to? Well, I'll take that debate and say that they have to have access to all of it. This personalized OmoteDriven medicine, artificial intelligence, what type of clinical workflows can we generate for our clinical practices as heterogeneous as they are? So digital health is...
A couple of us who aren't as into the tech as you are don't know what omic means.
Omic. So probably a scientific term that's come into the popular press now. So it comes from genomic, right? So it leads into what I was actually going to put up as well. That omic is it's not just sequencing technologies. Right? We can do that and sequence DNA and RNA and proteins, but you can also sequence how an individual is metabolizing red meat and that gut microbiome. You can sequence environmental factors that lead to genetic changes, and that's your exposome. So, and your epigenetic causes for disease. Yeah, it's a different way of looking and categorizing how conditions move from conditions to diseases. We have biosensors, which is a lot of what we'll speak about, but also social graphs. There's a lot of data on people out there in public health through social media, through data sharing. Right? So this new paradigm of data that's available for us to monitor factors related to health and wellness. And we'll go through a number of these in examples so we can see the breadth as it applies to cardiology, to healthcare, and specifically to heart failure. So it's an accelerating pace of change in medicine. It has been predicted by Ray Kurzweil that by 2030 we will have achieved the brain-computer interface. You'll be able to control computers just by thinking about them. And as far-fetched as that seems, 2001: Space Odyssey, it actually was published in the New England Journal of Medicine 2 years ago. where an individual who suffered a stroke and was locked in had a microchip implanted and was able to control and communicate through a computer. So it's not as far-fetched as we think it is. How does this apply to this accelerating pace of change in medicine? The EKG. Many people in the room are familiar with an EKG. It largely has not undergone innovation since its invention. I have to say from 1970, we're talking 1870, right? That has 280 or so working parts. But over the past 8 years, right, we've seen the miniaturization of the ECG to a smartphone single-lead ECG. This is an AliveCore device, FDA-approved device for telemetry monitoring, but it's one part, no wires. Well, that one part now is able to capture 6 leads on the phone, getting closer to 12-lead EKG. The smartwatch can now detect your EKG with a wristband, just touch with both arms. And I can show this to you later. So one part, and I don't know if I can play this here because I don't have a mouse, but you can detect heart rhythm and rate with 0 parts. And that is a camera behind a mirror, or embedded in a mirror that looks at capillary flow. You can imagine my face that goes from pale to red, pale to red. And you'll have this slide set and hopefully you'll be able to see that there. So it is the progressive miniaturization and mobilization, not just healthcare, now we're talking about tertiary diagnostic devices. The same holds true for ultrasound technologies that now can plug into your phone versus a $250,000 refrigerator size technology that's only in the healthcare system or at your clinic. And then this miniaturization has given rise to numerous technologies. And what's on the horizon is quite fascinating, but there are tens of thousands of new innovations. And so a lot of excitement around it. There's rings that can detect sleep apnea and sleep patterns, circadian rhythms, smartphone eye exam, smart necklaces to detect thoracic impedance in heart failure patients, smart pills that we'll see as examples for medication compliance monitoring, but also smart clothes for passive, non-contact monitoring of respiratory rate, heart rate, and activity. Who actually I tried on my dad, who had chronic lung failure, and even laboratory testing. Human genome sequencing 2 decades ago used to require an incredible amount of computer power in technology that would probably fill this room at a cost of $6 billion. It can be done on a USB-sized device now that costs about $100. So we're moving, as yet, to a different paradigm for data and technology-driven healthcare.
Sanjeev, are you going to show how simple it is to use the AliveCore? We'll hold that to the end.
I can show it to you guys. For those of you who have not tried it, and I still have one, we'll use Tabby's. But for you to actually experience this, right? And it's usually an aha moment once you do. You might be able to pass it around now.
Anybody, I think after your lecture during the Q&A portion, or at 2:30, anybody who wants to try it, I'm happy to let you use mine. It's so easy.
And once we do, we can use that as a case example of how we actually use it in clinic. As a practitioner tool, but also as a patient tool, regardless of age, regardless of their literacy on technologies, how they're using that device. And we can open up that conversation, because I think many of you will take interest in the specifics of how you can do that. So, as we've seen technology, we're also seeing system-driven change. And RAND is the right location to be able to introduce this. That these are not pebbles in the pond type of moves in healthcare. These are large, sweeping, potentially sweeping changes when we see a merger between a pharmaceutical supply chain and a health insurance company. What does that mean for the future of healthcare? And in this example, for 25 million of their subscribers, we've not seen this type of change before. We see Alphabet, i.e. Google's healthcare arm, that now has access to tens or hundreds of millions of patient health records, and are able to apply now advanced artificial intelligence and machine learning algorithms to create new risk prediction models. We ask questions: should they have the potential? Well, on one hand, there should. On the other hand, they are doing this. So again, yet another change in that chess game, that move that we can't deny. And finally,
Where are they getting the health records from?
so they have partnered actually, so two things, I'm glad you brought it up. The first was with the NHS in the UK. They gave them a sample of 75 million patient records and said, what can you do with it? And that's it's almost like a blank check to a company like that with their data scientists. But more recently, they applied their predictive algorithms to 5 US healthcare systems, UCSF, Stanford, and 3 others, and compiled a data set of 46 billion electronic medical record data points, and tried to create new risk prediction algorithms. And as an example was the atherosclerotic cardiovascular disease risk prediction tool. Now you have so much more data in there, radiographic data, laboratory testing data, structured and unstructured data. So it's happening in the US as well. So they're getting data through partnerships. We need to have what we're doing at the American College of Cardiology on facilitating the partnerships, but it is through these types of partnerships, not just acquisition, but academic and clinical partnerships. And you guys have probably seen the recent announcement yesterday from Amazon, Berkshire Hathaway, and JP Morgan's $60 billion promotion for what they're able to do in healthcare by appointing Dr. Atul Gawande as their CEO. Whatever these headlines do mean, whatever these headlines mean or they don't mean, these are big changes in the future delivery of healthcare. And even if they fail, we'll learn a lot from it, but it won't stop for the next chess piece to move.
So what's fascinating about that choice is, can you say a little bit about Atul Gawande? It's possible that some of the people here don't know about his work, for instance, on the checklist.
Sure, so I don't personally know him, but he's somewhat of a hero in medicine. He's an oncologic surgeon at Harvard and also at their public health school. But he has been primarily responsible for creating a system of thinking with patient care in surgery on checklists, on us needing to verify and re-verify in a team-based approach what we're doing for patient care. And he published a book called The Checklist Manifesto, which I would recommend everybody to read. It is what has probably changed the last decade of surgical care, but it's not about technology, right? It's about people and human-centric innovation and how you can change that. So he's also a writer for the New York Times. He's an orator, and he's gifted. His English prose is just exceptional. So, but now that he's leading, healthcare transformation to start with 1 million people, it'll be very interesting to see what will happen next. So, to cap off excitement is always money, right? And this is digital health venture capital from Rock Health out of San Francisco. They're an aggregator of what's going on in health innovation. And there has been a really rapid rise up to $6 billion in 2017, which is projected in 2018 to be $40 billion of investment in digital health startups. That's artificial intelligence, that's new technologies that you've seen. So again, the message of that a lot of what we're discussing is here and now, but this is an ongoing evolution where there is plenty of investment, plenty of interest, and it's moving at a pace that we on the ground in healthcare or in research right now cannot keep up. So as there's a lot of promise and a lot of hype, well, there are a lot of challenges. And in using heart failure, and to this audience, which of course you will know as just as well as I, that it is truly dynamic risk. The questions always come up, why can't we move our 30-day readmission rate? Why can't we move our heart failure mortality rate? How come we can't change healthy eating, right, for our heart failure patients? It's no different than any other chronic disease patient population. Those from public health in the room can certainly correct me, but it's because of dynamic risk. No two patients are the same. And if we look at heart failure in its paradigm, we have an at-risk group who may not develop heart failure for a decade or at all. To those who have chronic heart failure, they have a 30 to 50% acute decompensation risk at 1 to 2 years. Then moving from the hospital to home, transitions of care. That's an entirely different patient population and how we need to approach them with resources and other examples in technologies, mitigating readmission risk. Once a heart failure patient has one admission for heart failure, their 30, 60, 90, 180-day readmission risk can approach 70%. So again, a different group based on risk. Finally, advanced heart failure, those that need advanced therapies. We're not talking about readmission risk at this point. We're talking about morbidity and mortality reduction in this cohort. Very high cost, very high resource intensive patient population. And finally, the last one that may be the most important, and that's palliation. That's how do we de-escalate our care in a group of people who already have the maximum of care that has been delivered to them. And that has quality and costs completely in it. We've heard about the scope of the problem, so I'll skip over this. My statistics are, I think, a year older than yours, right? So, but you know, our quality of care that we've delivered in the United States has largely not changed in the last decade. If we look at diabetes, hypertension, cancer screening, medical treatment, well, we've seen reductions in tobacco cessation. We largely have seen a plateau with the proportion of patients that are getting care. You know, costs of care are going up, resource allocation is going up, yet the quality of care that we're delivering has been largely unchanged. Well, we'll tie one thing into it, and I'll make that association even if it may or may not exist, and that is how we are delivering care. And this is people, human-centric innovation. A very nice study done on, well, electronic medical records are our fulcrum and our Achilles heel for how we can deliver healthcare. And if we look at just time spent documenting electronically for patient care, this particular study showed for every 1 hour of patient care, there can be upwards of 2 hours of additional EMR time. And I see a lot of heads nodding. And I have 19 patients scheduled tomorrow, and I know I'm not making it home until 9 p.m. Right? And you guys are the same way. And so, you know, we know that our quality metrics, and this is where I think this room and group can think about how are we measuring quality, right? Is it the standard metrics that we're using, or when we have new variables that we're able to measure, how does that change? So I'll make that association even though I can't prove it to you, that one may or may not have led to the other. So like this, I don't always prescribe treatments, but when I do, they're backed by evidence. It's good. But I'll take you through some of the sobering things on now and challenges for how digital health is deployed for patient care. So we think that, if anything digital is going to harness people's wellness, and it's going to make them more fit. You give a worried well group of people a Fitbit, right, and a weight scale. And you say, you know, you're motivated. You are between the ages of 25 and 40. You're an earner. You don't have a chronic disease right now, so let's motivate you and give you the devices. Well, randomized to people who did not have digital devices to promote their activity or their weight, there was actually less weight loss in the group that had the Fitbits, and had the weight scales. It's because there's statistics in the background that show that 50% of people who have a Fitbit stop using it at 3 months. You wear it, sure, but have stopped using it for the health promotion. Now we have data to show that. Well, then how about heart failure? Well, we went from wellness to now chronic disease. And out of UCLA, Greg Fonero's group, they did the largest telemonitoring heart failure trial where they gave heart rate, blood pressure, weight scales, and oxygen monitors to heart failure patients who have been discharged from the hospital compared to standard care. Come see me in 7 days or in a month to 2 months, and look to see at what happened at 180 days. And in the two groups, there was no change in readmissions with digital health at 30 days or 180 days. I'll dive more into this a little bit later. Wellness, chronic disease, no difference. Randomized trial designs. In our group, Scripps, we said, what about high healthcare utilizers? People who access the healthcare system far too much than they should. And that can include diabetics, hypertensives, those with arrhythmias. So these are people who identified through their health insurance claims that had more than 4 unscheduled healthcare encounters for one reason or another. and randomize them to digital health, a live core, a smartphone glucose monitor, a smartphone blood pressure cuff, or all three if they needed it, to standard care, and showed that at 6 months there was no change in their cost of care. In fact, digital health might have led to a higher cost of care. Now, why is that? We criticize the technologies because we designed a study in 2011, 2012, but as we all know as healthcare practitioners, a high healthcare utilizer is a high healthcare utilizer for many reasons, other than being a high healthcare utilizer. Socioeconomic, right, psychiatric, whatever the reasons are, technology will not address those factors. And finally, cost effectiveness. The whole systems demonstrator, we'll see this in further detail. It's the largest randomized trial in the United Kingdom, in the world, out of the United Kingdom, for chronic diseases, diabetes, COPD, and hypertension, and showed that if you gave mobile devices to people at home, although it may reduce their readmission risk, it is at a very high expense. So it can work. Can it scale? The cost of care might preclude it from doing that. So it's supposed to do all that, improve outcomes, reduce costs, promote health wellness. So why doesn't it? I think this group I'd like to take from height to look at some of the granular details of why it does not. And the reason is many things of what we discuss now. It's not just about devices. Right? We have digital doctors with digital devices, and now we have digital patients. But this is also a moving paradigm. Clinical workflows, EMR integration, reimbursement. What types of devices are we using? Who are we giving them to? Do patients want to use these devices? Can they use the devices? Will they retain device use? What is the quality of these data sets that we're looking at? So there's several of the many reasons of why we face challenges with something that's so promising. Right? But how we generate that evidence is something that is a responsibility for all of us, and perhaps we all do it together. So realizing new opportunities requires harnessing non-traditional data sources. I hope that is sort of put out there now, right? That we have new data sources, how are we going to harness them? Several examples will follow. So can technology and data promote change? So let's look at it from how this is achieved. And for those of you who do remote patient monitoring, will know this type of algorithmic design. That an individual at home is using a device. That individual patient may interpret it. Their glucose monitor, their CGM, their glucose monitor, their alive core ECG, their blood pressure, whatever it might be. They're generating their own data through self-measurements. Now that data is uploaded. It's uploaded to a cloud-based transfer system. Cloud just meaning internet, or on an app. It has to get somewhere from there. So if it stops there, we have no way to glean insights on trends in patient care. So that data now has to come to clinic. Right? And it has to be interpreted. We have to filter out signal from noise. We have that now is that the human interpretation of digital data inform a clinical decision that then goes back to the patient. So from patient to clinic and back to patient, or the other way around. Right? But we have to complete a data loop in order for any of these tools to show effectiveness and also for how we are going to monitor outcomes and evidence. So medication compliance, it's a good example. I think we all see this as well. In cardiovascular disease, the majority of individuals change or stop taking their medications at 12 months. And this is polypharmacy. I think Carol, you mentioned, they take 7 evidence-based medicine heart failure medications, in addition to their 4 evidence-based medicine diabetes medications, and 2 depression medications, and something to sleep. So polypharmacy in and of itself is a risk factor, of course, for non-compliance. But what tools can we use? And we discussed, I think, Bob, earlier, MEMS caps, text messaging. We've deployed text messaging interventions for medication compliance in heart failure, COPD, and diabetes by creating a behavioral model for texting. It moves from how are you doing to what are you doing, to take your medications, to dietary, promote fitness. Text messaging is a very valuable tool to deploy, a very valuable and scalable tool that can be deployed in any health system or any clinic. MEMS bottle caps are another one, where every time it's twisted, that information is stored that bottle was opened. Does not necessarily mean the medication was taken, but we hope that it was. Right? But I want to show you new